Today we try to discuss new topic, drugs affecting cardiovascular system. And first topic, antiarrhythmic drugs. What is it, arrhythmia? Arrhythmia or dysrhythmia means an abnormal or irregular heartbeat. But firstly, we must remember about normal rhythm, about action potential. Так, что она тут? Сори. Мне надо пока слайдов, наверное, включить. Господи, ужас какой-то. And I think you remember that potential of action consists of 5 phases. 5 phases. Zero phase, when open sodium channel. First phase, when sodium flow into cells. Then open potassium channel and calcium channel. Will be influx calcium into cells, but potassium outflow. And next phase, when opening potassium channel and potassium outflow from cells. And phase 4, in this phase act sodium pump and sodium calcium exchange. And there are some type of arrhythmias. Arrhythmias are caused by abnormalities in generation or abnormalities in the conduction of the electrical impulse, or both, as in generation and in the conduction. What about causes of arrhythmia? Abnormal generation of impulse include enhanced or ectopic pacemaker activity and after depolarization. Abnormal impulse conduction include reentry and conduction blocks. Abnormal generation of impulse include enhanced automaticity by beta receptor stimulation, and atrial and ventricular cells may have pacemaker activity in hypokalemic condition. After depolarization may be of 2 types: early after depolarization and delayed after depolarization. Early after depolarization occurred during second or third phase, but delayed after depolarization occurred during phase 4. For example, digoxin toxicity. What about reentry? There has to be an obstacle to homogeneous conduction. Normal electrical excitation becomes extinguished at the end of the circuit due to collision of impulse. And unidirectional block prevents antegrade impulse, but retrograde impulse is propagated. Pictures of reentry, and you can see blocks of retrograde impulse, antegrade impulse, but propagate retrograde impulse. There are 2 types of arrhythmias: bradyarrhythmias and tachyarrhythmias. And as a result, we have two big groups for treatment arrhythmias, drugs for treatment bradyarrhythmia, and for treatment tachyarrhythmia. Drugs are used for bradyarrhythmia, and AV block include M-cholinergic antagonist antimuscarinic drugs. We discussed this group when discussed anticholinergic drugs, and the main of these drugs is atropine. And beta-adrenergic agonist, which stimulate beta-1 adrenal receptors in the heart. For example, adrenaline alpha-beta adrenomimetics and isoprenaline beta-1, beta-2 adrenomimetics. All of these drugs enhance excitability and conduction in the heart, and as a result, we used these drugs for treatment bradyarrhythmia and AV block. Drugs are used for tachyarrhythmias are called antiarrhythmic drugs, and there are many different groups, 4 main group and 1 group with different drugs. First group named sodium channel blockers. This group includes 3 subgroups, A, B, C, depend of action on action potential. First, A group prolong action potential, B lead to shorten action potential, and first C group no effect on action potential. First A include prokinamide and quinidine, 1B lidocaine and phenytoin, and C propafenone and plecainide. Second class beta-adrenergic blockers, propranolol, metoprolol, bisoprolol, esmolol, and other beta-adrenergic blockers. We discussed this group when discussed about adrenergic drugs. Third class potassium channel blockers, amiodarone, for example, sotalol, and dronidarone. And fourth main class, calcium channel blockers, verapamil and diltiazem. And some other antiarrhythmic drugs which used to treat tachyarrhythmias, atenosine, digoxin, and potassium and magnesium compounds. First class, named sodium channel blockers, and these drugs block sodium channel, open or inactivated sodium channel. And these drugs are used for treatment supraventricular and ventricular tachyarrhythmias, but different subgroups are used for treatment different types of tachyarrhythmias. First A class decrease the slope of force phase, spontaneous depolarization, inhibit potassium channels, and blocks calcium channels. And as a result, we can see slow down phase 0 depolarization, prolonged action potential. These drugs inhibit conduction, and as a result, increase the effective refractory period. You can see result of action of these drugs, prolongation of effective refractory periods by decrease flow of different ions. When used these drugs are used in treatment of both atrial and ventricular arrhythmias. But these drugs have different toxic effect. Quinidine is prototype of this group, and this drug has many different toxic effects. Inhibit action of the heart, and as a result will be bradycardia and AV block. And this drug has alpha adrenal blockers properties, and as a result will be hypertension. But these drugs can lead to paradoxal tachycardia, Tarset's points, by prolongation of QT interval. This drug has M-calina blockers action, and as a result may be visual disturbances, may be GIT disturbances, nausea, vomiting. This drug inhibit hematopoiesis, may be anemia, leukopenia, thrombocytopenia. Quinidine has hepatotoxicity action and may be side effects. Synchronism include some symptoms: blurred vision, tinnitus, headache, psychosis, and gastrointestinal upset. And when take high doses of quinidine. Procainamide. Procainamide less toxic than quinidine, but has adverse effect. Same bradycardia and AV block, maybe hypertension, because procainamide has ganglion blocking properties, and when put by intravenous, as a result will be hypertension. Maybe paradoxal tachycardia, maybe DIT disturbances, maybe agranulocytosis. When take long time, maybe lupus syndrome. And procainamide has can lead to hepatitis and liver insufficiency. Procainamide is metabolized by N-acetyl in the liver and is converted to N-acetyl procainamide, but these substances, N-acetyl procainamide, blocks only potassium channel. And as a result, the side effects may be torsade points in patients with renal failure, because N-acetyl procainamide is excreted by kidney. B subgroup, first B subgroup, lidocaine and phenytoin. These drugs block inactivated sodium channels and stimulate potassium outflow, but no effect on calcium channel. And as a result, will be shortened phase of 3 repolarization. As a result, decrease the duration of action potential and decrease the effective refractory period. When use these drugs? The main using of these drugs are to treat ventricular tachyarrhythmia when our patient has acute myocardial infarction, or when our patients with cardiac surgery. But these drugs does not mark slow conduction and has little effect on atrial or AV junction arrhythmias. What about adverse effects of lidocaine. I think you know that lidocaine is local anesthetic, and these drugs are used only by intravenous in this situation. And in high doses, maybe bradycardia, maybe hypertension, maybe toxic effect in the central nerve system and peripheral nerves. And as a result, maybe paresthesia, maybe disorientation. In high doses, maybe very severe inhibition of the CNS, and maybe nystagmus, drowsiness, slurred speech, agitation, confusion, and convulsion. But in high doses, lidocaine inhibit breathing center and vasomotor center, and maybe this is a result. Phenytoin. Phenytoin has anti-epileptic activity, and the main indication for phenytoin is epilepsy, different type of epilepsy, but sometimes used as antiarrhythmic drug. This drug has side effects, bradycardia, hypertension. These drugs inhibit CNS, and as a result, maybe nystagmus and ataxia. Phenytoin is cytochrome's inducer, and as a result will be tolerance. As side effects may be gingival hyperplasia, and gums over the teeth will be sometimes. And when take long term, as a result, maybe peripheral neuropathies and osteoporosis. First C group include propafenone, plecainide. These drugs are toxic drugs. And this is class of potent sodium channel blockers. These drugs have not effect on potassium flow and very low effect on calcium flow. And as a result, slow down zero phase. But do not increase the effective refractory period. What about using of these drugs? This class is indicated for life-threatening ventricular fibrillation and refractory or symptomatic supraventricular arrhythmia. When other drugs has not effect. Propafenone has different side effects. Again, bradycardia and AV block, because these drugs decrease automatically and conduction in the heart. Maybe hypotension. Maybe proarrhythmogenic effect, paradoxal tachycardia maybe. Propafenone has beta adrenal blockers effect, and as a result will be bronchospasm. And propafenone suppress hematopoiesis. As a result will be anemia, leukocytopenia, thrombocytopenia. In this picture, you can see different effects of different subclasses of first class on the ventricular action potential. First class prolonged action potential, and as a result, prolonged interval QRS and QT. First B class lead to shorten effectory refractory period and will be shortened QT interval. And first C class, not effect of duration of potential effector refractory period, and as a result on the ACG will be very long QRS interval. Second class of antiarrhythmic drugs, beta-adrenergic antagonists, names propranolol, esmolol, bisoprolol, atenolol, metoprolol. I think you remember all these drugs have and olol. These drugs blocks beta-1 adrenergic receptors in the heart and as a result diminish phosphase of depolarization and depress automaticity, prolong AV conduction, and decrease heart rate and contractility. What about using of this drug? These drugs are used to treat both types of tachyarrhythmia, ventricular and atrial, used for atrial flutter and fibrillation, and for AV nodal reentrant tachycardia, and to prevent life-threatening ventricular arrhythmias following a myocardial infarction. But esmolol has very short duration of action, and esmolol is used only by intravenous in acute arrhythmias that occur during surgery or emergency situations. You must remember this. What about adverse effect? All beta-adrenal blockers lead to bradycardia as a result of blockade of beta-1 in the heart. Will be hypertension. I think you remember that these drugs blocks beta-1 in the juxtaglomerular apparatus in the kidneys and as a result inhibit secretion of renin, and as a result will be inhibition of renin-angiotensin-aldosteronic system. Maybe fatigue, sometimes maybe depression if these drugs can cross blood-brain barrier and inhibit sympathetic action in the CNS. For example, these effects have propranolol and metoprolol and less action of bisoprolol. Sometimes maybe insomnia. These drugs have sexual dysfunction as side effects because blocks beta-2 in the vessels and as a result contraction of these vessels. Withdrawal syndrome as side effects. When patients stop taking these drugs, as a result will be acceleration. In this situation will be acceleration of tachyarrhythmia. If we treat ischemic heart diseases, will be attack of stenocardia. If we treat hypertension, will be hypertensive crisis. For non-selective beta-adrenergic blockers, maybe other side effects. Bronchospasm, because non-selective beta-adrenergic blockers blocks beta-2 adrenal receptors too. Maybe hypoglycemia as a result of blockade of beta-2 in the liver, and maybe spasm of peripheral vessels. What about potassium channel blockers? Third class of antiarrhythmic drugs. As you understand that these drugs blocks potassium channel, and as a result prolongs third phase of repolarization. But these drugs have not effect on zero phase. And these drugs inactivated sodium channels and have effect on calcium channels. Effective refractory period will be very long as a result. These drugs inhibit myocardial contractility, and these drugs decrease the heart rate. Different indication for different drugs. Dronedarone is used to treat only supraventricular tachyarrhythmia, but not to treat ventricular tachyarrhythmia. Amiodarone and sotalol are used for treatment as supraventricular ventricular tachyarrhythmias. These drugs, especially amiodarone, has action same as first class, second class, and fourth class. These drugs block sodium, potassium channel, calcium channel, and these drugs blocks beta-adrenergic receptors. But sotalol has more effect on the beta-adrenergic receptors than amiodarone. What about adverse effect of amiodarone? A side effect may be decreasing of myocardial contractility. And if our patient has different diseases of the heart, for example, ischemic heart diseases, these side effects will be more severe than if our patient has not these diseases. Maybe low blood pressure, maybe bradycardia, and AV block. Amiodarone has iodine in his structure, and as a result, act on the thyroid gland, and maybe different dysfunction of thyroid gland, maybe hyperfunction, hypothyroidism as side effects, maybe hypothyroidism, and maybe thyroiditis when a patient take amiodarone. These drugs have side effects, pneumonitis, and fibrosis of lung. What is this? What is it? Pneumonitis? Pneumonitis is non-infectional inflammation of lung. And after that will be fibrosis. Amiodarone is lipophilic drugs, and as a result, deposit in different tissues, include lung, include liver, include skin and eyes. And as a result will be deposition of microcrystals in cornea of eyes and skin. And as a result will be blue-gray skin discoloration. And will be photosensitization as a result. Sometimes, very, very rarely, maybe bronchoconstriction. And amiodarone has inhibitory action of some type of cytochromes. And as a result, may increase level of different drugs, and as a result, maybe toxic effect of different drugs, include amiodarone 2. What about calcium channel blockers? These drugs are used to affect only on calcium channel, no effect on other channels. Blocks both open and inactive calcium channels, and as a result, slow down phase 4 of spontaneous depolarization, slow down conduction in tissues, dependent of calcium currents, such as AV node, and prolong the effective refractory period. But verapamil and diltiazem have different structure. Verapamil is phenylalkylamines group, but diltiazem is phenothiazepines. And these drugs have different effect in the heart and in the vessels. Verapamil has more effect in the heart, but diltiazem has both action in the heart and in the vessels. And as a result, these drugs inhibition action of the heart, more arterial action, and as a result, use to treat only supraventricular tachycardia as antiarrhythmic, because these drugs are used to treat arterial hypertension, ischemic heart diseases too. We'll discuss these drugs again when discuss drugs to treat ischemic heart diseases and to treat arterial hypertension. What about side effects? These drugs inhibit cardiac function and will be bradycardia, AV block, and acute cardiac failure. Maybe hypertension, because decreased calcium flow in the smooth muscles of vessels, and unknown mechanism of edema of leg and foot. And these drugs, as a result of decreased level of calcium in the smooth muscles of gastrointestinal tract, has a side effect, constipation. What about other antiarrhythmic drugs? First of these drugs, digoxin. Digoxin is cardiac glycoside. Cardiac glycoside have mechanism of action, blocks sodium, potassium ATPase. As a result, increased level of sodium in the cells. High level of sodium stimulates sodium-calcium exchange. Calcium flow into cells, stimulates interaction between actin and myosin. And other indication for digoxin, for cardiac glycosides, is heart failure. For digoxin often is used to treat congestive heart failure, but sometimes used to treat acute heart failure. These drugs shorten the refractory period in the atrial and ventricular myocardial cells, while prolonging the effective refractory period and diminish conduction velocity in Purkinje fibers. Digoxin has negative drama and chronotropic effect, decrease conduction and atomicity of heart, but has positive inner and matmotropic effect. Digoxin as antiarrhythmic drugs is used to treat supraventricular arrhythmia. But as a result of this effect in the heart, may be side effects, tachy or bradyarrhythmias, ventricular tachyarrhythmias, atrial tachyarrhythmias, may be extrasystole, but may be severe bradycardia and AV block. Digoxin has extracardial effect, enhance diuresis, enhance tone of smooth muscles, and as a result will be different GIT disorders, will be vomiting, will be diarrhea, maybe anorexia. And side effects in the CNS may be disorientation, maybe depression, maybe psychosis as side effects, maybe xanthopsy as side effects. And now digoxin is used very rarely. What about adenosine? Adenosine is naturally occurring nucleoside, but at high doses it decreases conduction velocity, prolongs the refractory period, and decreases atomicity in the AV node. It activates potassium channels in the AV node. These drugs is used to treat acute supraventricular tachycardia. Only by intravenous, these drugs, adenosine, has very short duration of action, only 10-15 seconds, and not very toxic. Maybe side effects: flushing, chest pain, hypertension, and bronchospasm. Bronchospasm more often may be in patients with bronchial asthma. What about potassium and magnesium compounds? Magnesium compounds decrease flow of different ions, sodium, calcium, potassium into cells, and magnesium is used in acute situation by intravenous. But these drugs has many different side effects. Maybe very low blood pressure, maybe bradycardia, maybe AV block, maybe depression of the CNS, and these drugs inhibit activity of breathing center and maybe apnoea as side effects. What about potassium compounds? Potassium compounds prevent flow of sodium into cells, and as a result, enhance level of potassium in the cells and prolong potential action potential. And more often, potassium compounds is used to treat different tachyarrhythmia when our patient has hypokalemia. And if we put very high dose of potassium compounds and maybe arrest of heart, and we must give only low doses as need for this patient. What about re-entry? What drugs are used to treat in this situation? When our patient has re-entry blocks, will be unidirectional block, and we must give drugs which lead to bidirectional blocks. For example, first A group, first C group, and as a result will be bidirectional blocks, conduction of impulse in both sides, antegrade and retrograde, and as a result stop this tachyarrhythmia. Please have your question about this topic.
Well, no questions.
No.
No questions?
No.
Next lecture will be about drugs which are used for treatment ischemic heart diseases and to prevent ischemic heart diseases about hypolipidemic drugs.
Okay, great.
See you next lecture, and